Hello and welcome to this lecture. Today we are going to discuss about non-steroidal anti-inflammatory drugs, and I am going to present the case. Joy is a 48-year-old married mother of 3 active boys aged 12, 15 and 18. She enjoys attending her son's sporting event and providing mom taxi service for her sons and their friends. She also loves her part-time job as a hairdresser at popular salon. 7 months ago, Joy began noticing stiffness in both hands in the morning that lasted longer and longer. Stiffness now lasted more than 1 hour every morning and included hands, wrists and ankles. She also had increasing difficulty standing for long periods at work or at home due to foot and ankle pain. She began taking ibuprofen 800 milligram, which we know that ibuprofen is non-steroidal anti-inflammatory drug, 3 times daily, and found it helped her getting through her days with less pain and stiffness. 3 months ago, Joy noticed pain in her right and left shoulder when she would cut or blew dry her client hairs. She also began feeling extremely tired and short-tempered. She had no energy to do her usual activities. Ibuprofen was no longer effective for her pain or stiffness. One morning, Joy could not lift her arms at all without extreme shoulder pain. She knew it was time to get help. She had been speaking with her friends and they encouraged her to see the doctors. She saw her primary care physician, who examined her and ran a few preliminary blood tests. The blood test revealed positive rheumatoid factor (CCP) antibodies, elevated ESR and C-reactive protein. These all are actually biomarkers that are used to identify rheumatoid arthritis. C-reactive protein is very important biomarker, so they test these markers and they identify the elevated ESR and C-reactive proteins, and the rheumatoid factor has been found. And then Joy was informed of these results and her primary care physician referred her to rheumatologist to be seen as soon as possible. So that these all signs as indication of rheumatoid arthritis, and in the treatment of rheumatoid arthritis, Nsaids are commonly prescribed drugs. But why these occur, what is the reason behind, or what is the etiology behind? Inflammation is the main reason, and I start with the presentation where inflammation is a normal protective response to tissue injuries caused because of the physical trauma. It could be caused because of the chemicals, noxious chemicals or microbiological agents like bacteria, viruses, chemicals. Sometimes the drugs can also cause inflammation, or the use of the alcohol or hard liquor can be leading to inflammation and liver cirrhosis like an example. So inflammation is a quite generalized phenomena that can be seen in various tissues, and we discuss in pathophysiology and pathology that how inflammation occur and what is the process. So we are going to discuss briefly, and the common example is actually inflammation is rheumatoid arthritis. Why rheumatoid arthritis occur? It could be occur because of the production of inflammatory mediators, and we discussed several times different kind of inflammatory mediators such as prostaglandins and eicosanoids that are responsible, that can trigger the inflammation. So this is the slide that actually I taken this slide from the Robin pathology. We discussed before about that different factors that can cause inflammation. Environmental factors like infection, smoking can be responsible, or sometimes genetic susceptibility can be responsible for activation, especially T and B cells that actually what they happening that they join with the tissues and then what happened that they are responsible for the production of fibroblasts, chondrocytes and synovial cells. And the next thing that is very important, the inflammatory mediators that I'm talking about, prostaglandins, collagenase and other enzymes. Especially collagenase is the enzyme that is responsible to disintegrate or degrade a collagen, and collagen is very important part for the joint functions, for supporting the joints. So the release of the collagenase and the release of the prostaglandins or elastins or stromalacins and other enzymes are responsible to degrade the or destruct the bones, cartilage, and can lead to fibrosis or ankylosis. So this is the complete cycle. What is happening that it could be sometimes either genetic susceptibility or gene linked, or it could be caused because of the environmental factors such as smoking, infection, that every factor have their own reasons. Like environmental factors can be modify the enzymes that I mentioned here, that enzymatic modification occur because of the environmental factor. For example, we mentioned citrullination, or we can say that it is also known as citrullination of self protein, that is responsible that actually interact with antigen and antibodies, and then they affect actually chondrocytes or fibroblasts or the synovial cells that is responsible for the bones formation and bone maintenance of the bone. And then what happening they were there that the chondrocytes, what will happen that the release of the inflammatory mediators can affect the bone and can destruct the bone. So this is you already studied in your previous textbook, so you can read your pathology, you can understand the reason behind that. When we talk about treatment of rheumatoid arthritis, we always keep in mind that non-steroidal anti-inflammatory drugs in our mind. There are two ways that can we treat the rheumatoid arthritis. I mentioned on the left side, that is non-pharmacological treatment. On the right side we have pharmacological treatment. When we talk about non-pharmacological treatment, it could be treated because we can educate the patient, we can find out the etiology behind that inflammation, like environmental factor or infection that producing the rheumatoid arthritis. So we need to treat the disease, infection, which infection is what is the reason behind that rheumatoid arthritis. If a person is smoking is one of the risk factor that can increase rheumatoid arthritis. So first of all, we need to see whether the patient lifestyle or patient sometimes what happen that excessive stress is also responsible, or too much work and exercise activity, too much exertion also responsible for the arthritis as well. So we need to see the patient etiology. Then the medication is very important, because sometimes what happened that the arthritis could be caused because of the drugs. Some drugs is also responsible for causing rheumatoid arthritis. Like for example, antibiotics are one of the drugs that can be taken if in excess, can lead to affect the joints. And we know that rheumatoid arthritis is a disease which is also known as disease of the autoimmune disorder. So there are number of drugs such as different antibiotics that if it is taken for prolonged time can increase the risk of this autoimmune disorders. So rheumatoid arthritis is sometimes linked to the substance abuse as well. Some substances uses psychoactive drugs is another reason that can be responsible for rheumatoid arthritis. In that case, that if a person is taking substance abuses or psychoactive agents, it could result in malnutrition, and malnutrition then can trigger rheumatoid arthritis. So the etiology of the rheumatoid arthritis is very important. We cannot say that there is one reason or there is one etiology. The etiology is different because it is an autoimmune disorder. Sometimes some risk factors can potentiate autoimmune disorder. Sometimes some of the drugs, psychoactive drugs, because of their use can lead to malnutrition and then can affect the joints. Sometimes what happens that different drugs that are using, they can affect their joints directly and then can lead to rheumatoid arthritis. So it is a combination of different reasons. So the non-pharmacological treatments depend upon patient etiology. If we identify the etiology and we diagnose properly, then we can able to treat accordingly. Then the medication and lifestyle modification is very important. So these reasons we need to see first, and then allied healthcare like physiotherapy and occupational therapy could be helpful, or nurse-led care can be responsible for the treatment. When we talk about the drugs, pharmacological treatment, the first line of therapy is actually conventional synthetic DMARD, which stands for disease modifying anti-rheumatic or anti-rheumatic drugs. So D stand for disease, M stand for modifying, A stand for anti, R stand for rheumatic, and D stand for drugs. So we can give these DMARDs as a conventional first line of therapy, along with the additional therapy if patient is not getting well, with the use of NSAIDs and corticosteroids in combination. Whereas in the second line of therapy is biological DMARDs or the targeted synthetic DMARDs. So the first line of therapy is more conventional synthetic, whereas second line of therapy is more biological or more targeted treatment. So if we take a look of this diagram, NSAIDs have an important role in the treatment of rheumatoid arthritis. So the non-steroidal anti-inflammatory drugs, they having a number of functions like antipyretic, analgesic, anti-inflammatory activity, and how they work by inhibiting cyclooxygenase enzyme that is responsible for catalyzing the first step, which is the prostaglandin biosynthesis. So what they are actually doing, they are inhibiting the cyclooxygenase enzyme, and by inhibiting the cyclooxygenase enzyme we able to treat. We will see in our next lectures, next slides. Then this lead to decreased prostaglandin synthesis. As we discussed before, that one of the main inflammatory mediators is prostaglandins. And how can we reduce the prostaglandin? The answer is by reducing or inhibiting cyclooxygenase enzyme that is responsible for the function, especially for prostaglandin synthesis. So the decrease of the prostaglandin synthesis is beneficial and can helpful not only in that case, but in especially in rheumatoid arthritis as well. Aspirin, however, have proven to be beneficial for primary secondary prevention, especially for cardiovascular events. We all know that in aspirin has been not only given for just not as a treatment of pain, but actually aspirin is also used because it having used for treatment of especially not a treatment, for especially prevention of primary or secondary cardiovascular diseases, such as if patient having different cardiovascular diseases such as heart attack. In these cases that we can give aspirin, and it is also used for the treatment of or controlling the pain as well. So when we talk about list of our drugs, there are number of drugs. Drugs are classified such as an NSAIDs or other analgesics such as acetaminophen, which is not belong to NSAID, but it is a general analgesic agent. Then drugs for arthritis, this is a list as has been given, and then we have drugs for the treatment of gout. When we talk about aspirin and other salicylic acids, it was the prototype, especially first prototype for the traditional NSAIDs that was officially approved in 1939 by FDA, and then most commonly used is salicylic acid derivatives. And we all know that salicylic acid actually can also be extracted from the willow, from the bark, and it was initially identified accidentally. Salicylic acid initially identified from the willow bark, and then we prepared the first drug as an aspirin in 1939. So, and there are different derivatives that commonly used. What aspirin is doing, the aspirin is rapidly deacylated by esterases in the body, thereby producing salicylates, which is anti-inflammatory, antipyretic, and analgesic effect. So the drug is actually, if we take a look of the structure, I am not going to go to explain the structure, but What is meant by deacylated? Deacylated, the word can be split up into two parts, de and acylated. So it means aspirin consists of the acetyl group. What actually is doing that? What happened that when aspirin has been taken inside the body, when a person take aspirin because of the pain, the acetyl group inside the aspirin has been detached, and that is responsible for producing the metabolite, the active bioactive metabolite, which is salicylates, that has an anti-inflammatory, antipyretic and analgesic effect. So I am not going to explain the structure, but in simplest term, aspirin consists of acetyl group, which is a functional group. The removal of that functional group is known as deacetylation, and that deacetylation then responsible to produce the metabolite or the product, which is salicylates, and that salicylate is responsible for having anti-inflammatory, antipyretic and analgesic effect. So what is meant by antipyretic? Antipyretic means it is used for treating the fever, if for example high temperature, or analgesics for pain management and anti-inflammatory as well. That's why NSAIDs have three functions, not only anti-inflammatory, antipyretic but analgesic. They are also responsible for the blockage of prostaglandin synthesis. I already mentioned that prostaglandin is very important as an inflammatory mediator, and by blocking the prostaglandin synthesis through cyclooxygenase can help in reducing the inflammation and can act as anti-inflammatory. Furthermore, by decreasing the prostaglandin synthesis, salicylates also preventing the sensitization of pain receptors, both mechanical and chemical stimulus. So how these drugs can helpful in reducing the pain? By reducing the sensitization of the receptors that is responsible for pain management, and that then helps to maintain both mechanical or chemical stimuli. So this is a picture. If you take a look of this picture, let me draw and explain to you. Like if you see, this is the red point. This red point is actually presenting the acetyl group. So aspirin is consist of that acetyl group, and what happened that when it enter into the body, that what happened that deacetylation occur with the help of enzyme known as esterase enzyme, and that deacetylation is responsible for producing the salicylic acid. And that salicylic acid is actually active for example, that are producing as an anti-inflammatory activity. And they mention here that the process like by deacetylation through esterase is responsible for producing the salicylic acid, and then for example this acetyl group, what happened that it become inactive, they having no role. So this is actually main role as an anti-inflammatory or antipyretic or analgesic activity. So that's the structure they are going to talk about. When we talk about their pharmacological activities, the pharmacological activities, they have so many. As an anti-inflammatory, I already mentioned, as an analgesic effect or antipyretic effect, and it also have an effect on the respiratory action. So it have an effect on the respiratory system, like for example aspirin has been contraindicated, especially if a patient having asthma. Why? The answer is very simple, because we know that aspirin is responsible for inhibition cyclooxygenase, and by inhibition of the cyclooxygenase there will be reduction of the prostaglandin synthesis, and the reduction of the prostaglandin synthesis actually activate the other pathways like lipooxygenase pathways. So the inhibition of Cox pathway activate lipooxygenase pathway, and the activation of the lipooxygenase pathway trigger the increase of the leukotrienes, and trigger of the leukotrienes then can increase the risk of bronchospasm and asthma exacerbation, which leading to complication in asthma. So it has an effect on the respiratory system. Then it also have an effect on gastrointestinal effects, like it can increase the acidity, stomach acidity, and it can affect especially in patient that having ulcers. So in the chronic ulcer or in ulcer patient that having ulcer, NSAIDs is contraindicated. So what is the reason behind NSAIDs that has been contraindicated in ulcer, especially peptic ulcer? the researchers found that it could, as we know, that it could inhibit cyclooxygenase Cox-1, and that inhibition of Cox-1 leading to reduction of the prostaglandin synthesis and especially its cytoprotective effect on the gastric mucosa, and then it therefore therefore increase the susceptibility to mucosal injury. So that could be the reason that it is contraindicated. So what is the reason behind that aspirin is have an effect on the platelets? Let's need to see this picture. If you take a look of this picture, the important thing is that the stimulus, and if you see there are different mediators that are playing an important role. So I'm going to only focus on the specific mediators. Let me draw. So the important thing in this case is actually, you can see this is Nsaids. If you take a look of this, and if you take a look of it, it also affected thromboxane. So what is important, that the Nsaids is responsible to inhibit cyclooxygenase, and among the cyclooxygenase it can inhibit the thromboxane, and we know that thromboxane is important for aggregation of the platelets. So what these drugs are doing, that by blocking the thromboxane, and the aggregation of the platelets will be stopped, and then obviously it affect the platelets aggregation. But if you take a look, it can also affect the other mediators. I'm not going to explain in detail, but the main thing in this case is that these drugs are affecting thromboxane, and thromboxane is very important for aggregation of the platelets. And then with the use of the aspirin or Nsaids, especially they affect the thromboxane and they affect the platelets aggregation. The other effect on the kidney, if you take a look of the last point, is that it can affect the kidney and it can cause analgesic nephropathies such as interstitial nephropathy. So the long-term use of such as acetaminophen or aspirin or non-NSAIDs can responsible for interstitial nephropathy. So this is there are multiple effects of the NSAIDs on especially on different organ systems. So they look at this picture, they are talking about NSAIDs having strong anti-inflammatory, analgesic and antipyretic effect, and when we compare it with acetaminophen, the main difference is that acetaminophen has weak anti-inflammatory effect. And for example, if I already discussed that especially NSAIDs and especially aspirin is contraindicated in patient having asthma. So what will be the alternative? So the alternative in asthma patients especially is the use of acetaminophen for analgesic and antipyretic effect. And usually is a common observation that patient usually don't take NSAIDs or aspirin if you have fever, high fever. So patient usually take, or doctor usually prescribe acetaminophen when patient having high fever. The use of more NSAIDs is having its analgesic effect, especially pain, to maintain the pain, to reduce the pain, or it also having an anti-inflammatory effect, or for the treatment of the cardiovascular, especially heart attack. So that's why patient usually takes sublingual aspirin, as that sublingual aspirin helpful in case of the heart attack or to prevent the heart attack. So how the effect is acting, how aspirin is acting, it acting like irreversibly inhibit platelets, especially cyclooxygenase, and that the pathway that is inhibiting is the prostaglandin. We know that the process for synthesis of the prostaglandin from the arachidonic acid that released from the membrane phospholipids, and that arachidonic acid is responsible for production of the prostaglandin that is responsible to produce thromboxane. So what aspirin is doing, that they decreasing the production of prostaglandin and then interfering thromboxane, and we already discussed that thromboxane is very important in platelets aggregation. So that's how it works. This is a picture of the renal effect of NSAIDs, inhibition of the prostaglandin synthesis. So what is happening, that the drugs actually they having renal effect, and then how it can cause effect. You can take a look of that increase disease state leading to increased vasoconstriction. And let me discuss with you with this picture. For example, patient that has been treated with NSAIDs, if patient that is treated with NSAIDs, it could lead to vasoconstriction, and then NSAIDs inhibit prostaglandin synthesis as mentioned and leaving vasoconstriction unopposed. So that vasoconstriction is actually responsible for renal obstruction, and that is responsible for interstitial nephritis. So if a patient is not no treatment, no NSAID, then there will be no prostaglandin and is not no vasoconstriction. So the renal blood flow is not blocked. So the usually prostaglandin is mentioned here, that prostaglandin is synthesized normally antagonize intrarenal effects of vasoconstriction. But what happening with the drugs and with NSAIDs, it can increase the vasoconstriction and can affect the renal blood flow. So you can see that the decrease of the renal blood flow is responsible, and that decrease of renal blood flow along with the renal disease and cardiovascular disease can further produce vasoconstriction and then can affect the overall hemostasis or homeostasis of the body. So for example, a patient having cirrhosis and nephrosis or heart failure plus diuretic can further decrease the blood volume and can cause vasoconstriction. So you can see there are multiple reasons for especially the effect, renal effect, when we talk about NSAIDs. So the therapeutic use is as an anti-inflammatory, antipyretic and analgesic effect as we discussed before. It also used as an external application as well for anti-inflammatory effect or analgesic effect, and it also having cardiovascular effect as I already mentioned for heart attack. The pharmacokinetics after oral administration, the unionized salicylate is passively absorbed partially from the stomach and mostly from the upper small intestine. So the absorption of this drug is in the small intestine or it is in the stomach. The main thing is that the salicylates or the unionized salicylate is responsible for producing the effect. As we discussed in the previous slide, that aspirin will be deacetylated, and that deacetylated is responsible for producing the salicylates, and they are responsible for producing the effects. Salicylates also exhibit analgesic activity at low doses as well. So when we talk about the dose dependent effect of the salicylates, dose is very important because at low dose it is analgesic and antipyretic and analgesic and antiplatelet, but at increasing of dose is responsible for anti-inflammatory. And then if the dose of the drug is quite high, like mild, severe to lethal, it can cause vasomotor collapse, coma and dehydration, especially the intoxication of certain level of drug can lead to coma and vasomotor collapse as well. So the adverse effect of these drugs is epigastric distress. It can cause nausea, vomiting. It can reduce the level of platelets, as obviously I mentioned that it affects the thromboxane, and then obviously it reduces the platelet segregation. It can impair respiration like in asthma and can exacerbate asthma. Then it can cause hypersensitivity reaction as well. So what is epigastric pain? Mean the pain like abdominal pain, abdominal distension, heartburn, and sometimes gas, nausea, and that it could be reversed with the use of the aspirin. Then hypersensitivity reaction could be occur like the rashes that can be seen here. These red spotted can be seen with hypersensitivity reaction. And the aspirin must be avoided during pregnancy and while breastfeeding. We need to keep in mind that there are a lot of drugs that can be interact with the use of the aspirin. So aspirin especially is contraindicated with the heparin, because we already know that aspirin is responsible for reducing the aggregation, platelet aggregation. Heparin have the similar function. So if aspirin has been used with the heparin, it could increase the chance of hemorrhage or bleeding disorders. Then also it is contraindicated with some of the drugs with treating gout. So the drugs with the gout has been also contraindicated with the salicylates. Furthermore, it also increases the plasma concentration, leading to the prolonged half-life and toxicity of certain drugs. Like these are the list of the drugs their concentration will be increased and their half-life become high when we use in combination. So they have a lot of effects. Toxicity is already mentioned that high toxic level lethal dose can lead to vasomotor collapse and coma. So the toxicity consists of nausea, vomiting, marked hyperventilation, headache, mental confusion, dizziness, and tinnitus, which is actually the ringing or roaring in the ear.
There's been a number of questions about Nsaids, and the recent issue in terms of the French minister saying that we should not use Nsaids in COVID-19. There's also this really good summary of the key points that's put out by a pharmacist organization in Canada, which we'll put a link to in the description below, that also goes through the salient points about the possible risks and benefits of Nsaids in COVID-19. But let's talk a little bit about what are Nsaids and what does it have to do with viruses. So Nsaids stand for non-steroidal anti-inflammatory drugs. And the reason why is because for a long time, the thing that reduced inflammation were steroids. So these were a new category of medications that were not steroids but could reduce inflammation. Probably the earliest one that was invented was aspirin back in 1899. More on that one later, very importantly. We'll talk, though, about ibuprofen. Ibuprofen is probably one of the most widely used NSAID in the world, and it's used to reduce inflammation, reduce fever. It's used for osteoarthritis, a number of indications for NSAIDs. Well, NSAIDs, among other things, have a special impact on an enzyme that we're going to talk about, which is Cox-2. Cox-2 stands for cyclooxygenase 2, as opposed to cyclooxygenase 1, which it also can inhibit, but that's not really germane to our discussion. What does Cox-2 do? It takes a substance called arachidonic acid, which will abbreviate AA, and it converts it into prostaglandins, specifically PGE2. Now, Cox-1 also makes thromboxane, and that is used in platelets, but that's not really germane to what we're talking about. What we want to look at here is the Cox-2 enzyme, which converts arachidonic acid into prostaglandin E2. Now, why is that important? Because prostaglandin E2 is involved with pain, which is why we would give it. It's also involved with fever, which you would see in a viral infection. But it's also involved in antibody production. Or more specifically, Cox-2 is involved in antibody production. And what NSAIDs do to that is they halt it. They prevent it. Now, antibodies are important. Antibodies are made by B cells, and B cells make these antibodies to go out into the serum and attack things that should not be there, things like viruses. So you could see why NSAIDs may cause a problem. Yes, while they get rid of pain and fever, they can also hit your antibody production. But NSAIDs, specifically ibuprofen, and to a lesser extent other NSAIDs as well, they also have another function because they also inhibit some other things. They apparently can inhibit viral replication. And it's been shown to hit the SARS-CoV, not 2, but the original, the one that was from 2002. It's also been shown to attack the canine version of coronavirus. And it's also been shown to be toxic and inhibitory to both influenza A and B. So the question is which one is it doing more? And you can see why there might be benefits on either side and risks on either side. What do we do? So this pharmaceutical organization that put out this statement from Canada that was prepared a couple of days ago, they say here, further research, including randomized controlled trials, is required to determine the impact of NSAIDs on coronavirus infection and subsequent disease. And they go on to talk about confounding variables. The NSAIDs could be treating comorbid conditions, which put them at increased risk of more severe COVID-19 disease. And so the bottom line is you need a randomized controlled trial. So I think the answer at this point is we don't know based on this data. So then I did something really weird. I went back in time to an epidemic of a viral illness that was a pandemic. And at the time, they actually had an NSAID, and it was given quite liberally. And so the question is, what happened at that time, and what were the observations? And it actually was really quite interesting. And here's a paper that was published in 2009, Salicylate and Pandemic Influenza Mortality, 1918 to 1919, Pharmacology, Pathology, and Historic Evidence. And we'll put a link to this as well in the description below. And what it talks about is that aspirin had just come out in 1899, and it was a fresh drug to be used at the time, and it was a great way to get rid of fever. And some people thought that if you could just treat the symptoms of the flu, the patient would get better. And one of the big symptoms of the flu, of course, was the fever. The paper goes into discussing what the toxic dosages are today based on what we know. At the time, people would be given large doses of aspirin until they saw toxicity, and then they would sort of pull back. They talk about 4 lines of evidence support the role of salicylate intoxication in 1918 influenza mortality: the pharmacokinetics, the mechanism of action, pathology, and official recommendations for toxic regimens of aspirin immediately before the October 1918 death spike. And for those who don't know, 1 grain equals 65 milligrams. So when we talk about grains, you'll see. The aspirin regimens recommended in 1918 are now known to regularly produce toxicities, and you can read about that here. We do know that salicylates cause immediate lung toxicity and may predispose to bacterial infection by increasing lung fluid and protein levels and impairing mucociliary clearance. And that the pathology of early deaths that we saw back in 1918 was consistent with aspirin toxicity and a virus-induced pathology. And remember, aspirin, which is a salicylate, is also an NSAID. So this kind of makes an interesting twist on the discussion about whether we should be using NSAIDs in COVID-19. And then, interestingly, it talks about the aspirin advertisements in August of 1918, and a series of official recommendations for aspirin in September, early October preceded the death spike of October 1918. And it's interesting that the young adults coming back from World War I were more likely, they felt, to take aspirin, whereas the lower mortality in younger children may have been the result of less aspirin use. And interestingly, the major pediatric text of the time in 1918, and remember, they have no antibiotics, they have no antivirals, they have no ventilators. Essentially, what would happen in a major surge recommended not aspirin, not salicylate, but actually recommended hydrotherapy for fever. These were the great thinkers working with what they had at that time. And we can see at the time that there was a dichotomy that was set up in the treatment of the Spanish flu back in the 1918, 1919. Those that really believed in the pharmacodynamics and pharmacokinetics of aspirin, and those that would treat with hydrotherapy. This is Dr. William A. Pearson in 1919. I'm quote, "None are so blind as those who cannot see that the average mortality of influenza patients treated by homeopathic physicians was actually only about 1/30th, and that's a 30, not 13th, but 1/30th of the average mortality reported by all physicians." And then Dr. C.J. Loiseau from Des Moines in 1919 says, "The German aspirin has killed more people than the German bullets have." So the question boils down to, what are we getting in terms of risk benefits of these NSAIDs and ibuprofen or even aspirin? Are we confounding the mortality of 1918 with the dose of aspirin? Some would say yes. Is this just a larger magnitude of the effect that we might be seeing with NSAIDs with COVID-19? I think it bears testing. I think at this point we don't have enough answers for that. I would say, though, that in my research of the 1918 Spanish flu epidemic and pandemic, I think there are some parallels that we might be able to learn from. Because if, in fact, we do have a surge in this country like what we are having in Italy, the question is going to be, what was it that worked back in 1918? And can we learn anything from there? Because we may very well be in a similar situation if we don't have ventilators as they didn't have, if we don't have pharmacological interventions as they didn't have back then, we don't have antivirals as they didn't have back then, and don't have antibiotics. In other words, is there some lesson that we can learn from them that we could apply in our own homes, for instance, to improve survival? I think that bears thought and deserves research. Thanks for joining us.
So this is aspirin that has been used. So thank you so much for today's lecture. Hope to see you again.